I'll just like to start this off by saying it's 8:30 a.m. where I am. I'm on the traditional ancestral and unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh. And we have a few fall colors here, and probably not as beautiful as where you are, but I'm very grateful as the seasons are turning. Today, I'm also grateful to have Janine speak with us today. Janine is an occupational therapist and an assistant professor at the University of Toronto, and her research is actually on understanding barriers to life participation in people with chronic kidney disease. And her interest is in fatigue and understanding fatigue and symptom management. So probably the best person that could be giving us this presentation. In terms of housekeeping, if you do have questions, you can definitely put something in the chat. I hear we have a bit of a robotic sound on my end. So if others have that, please put that in the chat as well.
It sounds good to me, so I think it might just be on that person's end. Sorry, Parveen, I think it might just be your connection.
Perfect, great. Your connection sounds fine, Janine, so I will pass it over to you.
Perfect. Well, thank you very much for that introduction, and I really appreciate everybody being here. It's good to kind of be a part of getting this sort of lecture series started again. So yeah, my name is Janine Farragher. As was mentioned, I'm an assistant professor from the Department of Occupational Science and Occupational Therapy at the University of Toronto. And it really is a pleasure to be speaking to you today about managing fatigue in kidney disease and what we know about this, and really what we can do about this problem that really is quite common in our patient population. So I thought I would start off just by spending a minute thinking about the significance of fatigue in the kidney disease population. So first of all, fatigue is the most common symptom experienced in most kidney disease populations. For example, it's been estimated that up to 70% of people on hemodialysis experience fatigue, and it is very prevalent in other kidney disease populations as well. So it really is a common problem. Not only is fatigue a common problem in this population, but it also really matters to patients. So some of you might be familiar with this initiative going on that's called the Standardized Outcomes in Nephrology Initiative. And if you're not familiar, it's a global research initiative that's been really working to identify the most important core outcomes to include in future trials in nephrology. And 202 patients or caregivers and 979 clinicians from 73 different countries were engaged and chose fatigue as one of 4 core outcomes to include in future hemodialysis trials. So really underscores the importance of this in this population. In other studies, for example, here in Canada, fatigue has been chosen as a top 3 research priority of patients. And in the United States, patients have identified fatigue as the most important physical symptom to find better treatments for. So really, there's no question that we need to sort of think about and look for more opportunities to address fatigue, both for and with our patients. So what are we talking about when we talk about fatigue? What are the characteristics of fatigue? So, I mean, I think we all have a good understanding of fatigue essentially being sort of a feeling of tiredness. In kidney disease and in other chronic diseases, fatigue is often unusual, abnormal, or excessive. And it's also often disproportionate or even unrelated to a person's activity level or how much exertion they're doing. So it's primarily a difference in the frequency and the degree of fatigue felt in people with kidney disease and other diseases compared to the usual day-to-day fatigue that some of us can experience. Some efforts have actually been made to quantify this difference. So for example, one study estimated that people on dialysis have about 50 to 70% of the exercise capacity of what would be an expected norm in a healthy individual. So that translates really, when you think about it, to an impact on 30 to 50% of the activity that a person might normally be doing, where they would start to feel limited. And it turns out that this impact on sort of daily activity is the most problematic aspect of fatigue for patients. In the SONG initiative that I was mentioning earlier, the ability to participate in life activities was seen as the fundamental goal of treatment in general, because it symbolizes some indicator being able to live a life without being confined by the disease. I think this is helpful to keep in mind when we think about opportunities to intervene, because the objective becomes not just how do we make fatigue go away or how do we fix the fatigue. It's really about supporting patients in coping with fatigue so that they can participate more fully in their lives. And that should really be our goal when we're thinking about this. So beyond physical fatigue, there are mental and emotional dimensions to fatigue and kidney disease as well. So for example, a lot of people report decreased concentration, feeling especially tired after doing cognitive work. And people also frequently report emotional stress and burnout as well. So fatigue often encompasses these physical, mental, and emotional dimensions in kidney disease, and they all sort of come together to create sort of a complex fatigue experience. And then there's also the added dimension of post-dialysis fatigue in patients on hemodialysis as well. So the vast majority of patients on hemodialysis treatment experience an increase in fatigue after a hemodialysis session. And almost 30% of patients have been found to take more than 7 hours to recover from that post-dialysis fatigue. So this sort of phenomenon of post-dialysis fatigue is just another layer of the fatigue experience in the hemodialysis population as well. So we've already sort of touched on the physical, psychological, and treatment-related aspects of fatigue in this population. And I think it can actually be a really helpful way to break down potential causes, so we can identify different intervention approaches that could make a difference. So in terms of physiological factors that can contribute to fatigue in kidney disease, I think anemia is probably the most well-known, it's sort of the most obvious, and also one of the more easily identifiable causes of fatigue in this population. So in terms of other factors, there has been research to suggest that low-grade chronic systemic inflammation, can be common in kidney disease and in chronic disease in general, is actually also associated with fatigue, and so can be an underlying cause of fatigue. Other common complications of kidney diseases like uremia, malnutrition, hyperparathyroidism have been associated with fatigue in some studies, although the evidence hasn't been entirely consistent, and so I'm not sure that we entirely understand their contributions to the fatigue problem. There are medications that are commonly used in kidney disease, like statins and benzodiazepams, that can cause or exacerbate fatigue as well. And then comorbidities of kidney disease, like heart disease and diabetes, are also associated with fatigue, and so those things layer onto the fatigue experience in kidney disease as well. So those are the physiological factors. Then there are psychological or behavioral factors. So mood disorders like depression and anxiety are a major factor in fatigue and kidney disease. They are very common in this population, and they are strongly associated with fatigue as well. Common sleep disorders in kidney disease, for example, obstructive sleep apnea and restless leg syndrome, can certainly exacerbate fatigue as well via that sort of reduced sleep kind of pathway. Excessive use of substances like alcohol, marijuana, or other drugs has been linked to greater fatigue in this population. And then physical inactivity is another factor for sure. A lot of patients find it quite difficult to stay physically active, paradoxically because of fatigue. But this can unfortunately then create sort of a negative reinforcement loop where they're too fatigued to be physically active, and then they start to get deconditioned, and their fatigue just worsens over time. And then there are treatment-related factors that contribute to fatigue as well. So we've talked briefly about post-dialysis fatigue. It seems as though the rapid fluid shifts and hypertension that occur during hemodialysis often exacerbate fatigue. Dialysis inadequacy has been linked to fatigue. In terms of dialysis modalities, in-center hemodialysis patients do tend to experience the most severe fatigue, although it should be noted that people on peritoneal dialysis and people in earlier stages of kidney disease as well do also experience fatigue due to all of the other factors that we just talked about. So fatigue is not just a hemodialysis problem, it really is a problem across kidney disease populations. A less frequent hemodialysis schedule is associated with greater fatigue in that hemodialysis population. And then I think, it's really important to acknowledge as well that there is extensive responsibility involved in self-managing a chronic disease like chronic kidney disease. Self-managing dialysis and kidney disease, when you think about, if you're on dialysis, having to go to and from dialysis, plan complex meals, manage all these medications, monitor your fluid intake, all of these responsibilities would be exhausting for anybody. And so I think that's important as a factor to keep in mind as well, that not only are there these factors that are increasing the risk of fatigue, but there's also a lot of additional responsibility being placed on the patient that, requires energy to deal with. So thinking about, what is the best way to assess fatigue in this patient population? So I think there are a few criteria that you always want to consider when selecting any type of patient-reported questionnaire to assess something like fatigue. So we should be looking for a questionnaire that's first of all going to be feasible. Questionnaire burden is quite heavy in the hemodialysis population and in the kidney disease population in general. So looking for something that is as concise as possible, I think is important. We want it to be validated in the kidney disease population, really to ensure that it captures the aspects of fatigue that are the most salient and important to this particular population. For example, as part of the SONG HD fatigue initiative, the most important domains of fatigue identified were life participation, levels of energy, and the ability to think clearly. So when thinking about a measure to use, we would want to measure that capture those specific domains of concern. We're looking for a measure that has reliability data to show that it performs consistently over time, and a measure that has responsiveness data to show that it can accurately capture changes in fatigue over time as well, particularly if we do want to measure, for example, intervention outcomes in our patients. And then ideally, we'd like a measure that's culturally accessible, perhaps translated into a variety of different languages so that it can be used in a diverse patient population. So those are just some criteria to keep in mind if you're trying to sort of wrap your head around different measures to use. So Ju and colleagues recently did a systematic review where they identified all of the fatigue measurement tools that have been used for fatigue in the hemodialysis research literature specifically. And they identified 45 different measures that had been used. There were some significant limitations that I think really sort of highlight the need to improve the science around how we measure fatigue in chronic kidney disease. So, for example, 19 of the hemodialysis specific measures were developed and used without any formal validation. Measures were often limited in the number of relevant content areas that they covered. For example, only a third of these measures actually assessed the impact of fatigue on life participation, despite that being a top priority. Then psychometric research about reliability and validity of the measures was either often incomplete or missing altogether. So recognizing that there are some limitations in what is available in terms of tools, there are still some measures that I think are feasible and that can still be used to provide valuable information about fatigue in our population. And it's important to use the best available measure, but certainly to use a measure. Using the best thing that's out there is better than not assessing fatigue at all, of course. And so in terms of measures that sort of cover the most criteria that we'd be looking for example, the KDQOL-36 vitality subscale is a very quick measure. Again, it's only 4 questions, and it does have some validity data and covers some of those key content dimensions considered important to this population as well. Chalder fatigue scale covers a lot of the key content dimensions, although it does lack psychometric validation, but it does have that validity in this population. The fatigue severity scale is another one that has both reliability and validity data. Doesn't cover necessarily the breadth of key content dimension that the Chalder fatigue scale does, for example. And then measures like the visual analog scale fatigue and the Fukuda fatigue scale have some psychometric data to support them. And they cover a lot of key content dimensions relevant to hemodialysis fatigue, although they are a bit lengthier. So as you can see, there are pros and cons to all the different measures that are available. But in general, depending on your circumstance, depending on what is feasible in your population, measures like these can and should be employed to assess and monitor fatigue while we continue to advance measurement science in this area, because I think it is important to be asking patients about this and measuring this in a systematic way. The SONG group is also currently developing actually a hemodialysis specific measure of fatigue, and that measure is supposed to be standardized, psychometrically sound, and validated for the hemodialysis population. So this is what the measure looks like, and I believe it's still going through development research, but once it's ready, it will be a great tool to use, I think, both in clinical practice and in clinical studies as well. So that hopefully just put sort of on your radar some of the measures that are out there that you can sort of draw on if you are looking to kind of start assessing fatigue in your patient population. So moving on to the big question is what can we do about fatigue? How can we actually help our patients who do have fatigue once we've measured it and we see that fatigue is there? So I'm going to break it down in terms of strategies that the patient can use to sort of self-manage their fatigue, strategies that the clinician can use to sort of support and help with fatigue management, and then strategies that the family or caregivers can use as well to support the patient in managing their fatigue. So sort of breaking it into those three buckets. So starting with the patient's role in self-managing fatigue, first of all, I think we can support patients in communicating with the people around them about fatigue to help them get the support they need. For example, I know of a patient who said that she had developed a system with her family of ranking her daily energy level on a scale of 1 to 10 and writing it on a whiteboard in the kitchen every day. And that would help the whole family to plan for the day and set realistic expectations without her always having to raise every day about whether she's tired or whether she's not tired, and having those kind of conversations every day that can be exhausting in and of themselves. So ensuring that the patient's family and support systems have some sort of a communication system, or that they're comfortable to communicate, and that everybody is informed is a role that we can support patients in pursuing. I think we can support patients in staying active and engaged. We certainly do know that this is effective for fatigue management and for sort of increasing energy capacities. So in a systematic review that looked at the effects of exercise on a number of different outcomes, including exercise capacity, the results were significantly positive in favor of exercise improving physical capacity in both non-dialysis and dialysis chronic kidney disease patients. So exercise is certainly an effective intervention for fatigue in this population. However, there are certainly barriers to dialysis patients engaging in physical activity. For example, fatigue, a lack of interest, other symptoms like pain or fear of getting hurt are just some of the common barriers to exercise that have been reported by this patient group. So the question is, what can the average healthcare provider do to support patients in being more active? So Johansson and colleagues came out with these great suggestions. So first of all, I think we can ask patients about their physical activity levels, help them identify barriers to being more active and help them problem solve around those together. Recommend increasing activity if physical activity levels are quite low. And I think really the key is to set small and manageable goals. Even just going for a 10-minute walk around the block is a good start for somebody who really isn't getting out and being active at all. Providing educational materials about exercising. So there are a variety of good written and video resources that are out there about exercise for this population. And then if the patient is interested, also referring to a trained rehabilitation professional, whether that be a kinesiologist, physiotherapist, an occupational therapist, somebody who can support them in undertaking a structured exercise program if that's something that they are interested in. So I think those are some of the things that we can do to support patients in managing fatigue with physical activity. So what else can we do? We can help patients to follow their diet, which can prevent things like fluid overload, malnutrition, and other symptoms that can contribute to fatigue. We can also help the patient to stay on top of their medications and treatment regimens, taking medications as they're prescribed, getting to dialysis on time. And if you suspect that there could be challenges with memory or motivation, perhaps involving a dietitian, an occupational therapist, or a social worker can be helpful in those circumstances to problem solve around those situations. We can support patients in managing stress and the emotional aspect of fatigue. And I think that's going to look different for different people. But whether it's, suggesting meditation, getting out in nature, reading a book, getting social support from loved ones or others with kidney disease, we can really help patients to explore what could alleviate some of the stress that they are experiencing living with a chronic disease like kidney disease. We can encourage patients to practice good sleep hygiene to improve the quality of their sleep. So these are strategies that patients can use themselves to increase the likelihood that they're going to be able to get a night's rest. So some helpful tips are limiting daytime naps to 30 minutes to ensure that you're more tired at night. Avoiding stimulants, especially close to bedtime. Again, getting some physical activity or some exercise during the day so that the person is more tired at night. Avoiding heavier rich foods before sleep. Getting adequate exposure to natural light during the day as well. And then establishing a regular relaxing bedtime routine. Making the bedroom peaceful, limiting screen time, those kinds of things as well. These things can be helpful strategies for the patients to increase the likelihood that they will be able to get a good night's rest. So we can support patients in reframing their thinking around fatigue as well. As an example, cognitive behavioral therapy is one model that can be used to help reduce negative thoughts, feelings, and behaviors that are associated with fatigue. And really the goal is that the impact of fatigue, although the fatigue is still there, is not felt quite as strongly. And this approach actually has been found to be effective for fatigue management in other populations. So, for example, there was a randomized controlled trial done in multiple sclerosis that looked at the effects of cognitive behavioral therapy on fatigue and found that the group who received CBT had the biggest reduction in fatigue over a 6-month period compared to control conditions. There's actually a feasibility trial of cognitive behavioral therapy for kidney disease fatigue currently being conducted in the UK. I don't believe that data has come out yet, but that will certainly give us some good information about the potential for CBT in helping with kidney disease related fatigue as well. So we'll look forward to that study being concluded. And then finally, another thing we can do to support patients in managing their own fatigue is to teach them how to manage their energy expenditure on a day-to-day basis. And this is what my research is about, so I'll just tell you a little bit more about that. So energy management, we sometimes also call this energy budgeting, which is kind of an accessible way to talk about it with patients. It's really about taking the same conscious approach to managing energy that we often do with managing money. The goal of the approach is really to optimize the use of a person's available energy to meet their unique needs and goals. So really we can think about it as figuring out how to live on a reduced energy budget. And there are 7 core energy saving strategies we typically discuss with patients. So just to give you a sort of general sense of what these strategies look like. So first of all, eliminating tasks that aren't as important from one's day-to-day routine. So for example, setting up automated bill payments with the bank so that you're not having to spend energy paying your bills. Getting some help with grocery shopping so that the patient can spend their energy on something that might be more important to them. So simplifying tasks as well. So for example, finding simpler recipes to make for dinner than the person might be accustomed to making. Using assistive tools that can reduce energy expenditure during tasks. For example, a food processor is an example of a sort of assistive tool. A tractor stool, like this woman in the photo is using for her gardening, can be really helpful. So these kind of tools. Organizing the home or work environment. So it could be organizing a room, a drawer, a closet, really to make it easier and more efficient to navigate and work within those spaces. We all know the difference between how much energy it costs to kind of navigate a really messy or busy room versus a room that's really streamlined and simplified. And so that can be an energy saving strategy as well. Asking for assistance with a challenging part of a task rather than just deciding not to do it at all. So asking a family member to cook together, for example, or asking for help carrying in the groceries if one decides to go grocery shopping. So delegating some of the parts of the task so that it is more manageable and easier to do. Repositioning into a more energy efficient body posture, like for example, sitting on a stool while chopping the vegetables or sorting the laundry. I've had patients who have gone through our program who've told me that this simple suggestion just never occurred to them before, and it's been really helpful for them, just sitting down while they're cooking instead of standing. So this type of thing can I think really make a difference as well. And then slowing down and allowing enough time to complete things as well. So for example, breaking up the vacuuming and doing just one room per day rather than trying to sort of tackle the whole house, which can then lead to extreme exhaustion, and it takes a long time to recover from that sometimes. So really pacing oneself. So what do we know about this sort of energy management education approach? So there is some evidence from other populations that this approach can be effective. So as part of my PhD research, I did a scoping review looking at all the evidence on energy management in different chronic disease populations. The black boxes in this figure are studies that reported positive findings associated with energy management in those domains that are listed at the top. And really just the general message, it takes a while to kind of digest this, but there are quite a number of black boxes in different domains you can see. So especially when you look at fatigue and the impact of fatigue on functioning. And notable as well, 9 of the studies that are listed here were randomized controlled trials, so there is some RCT data. But unfortunately, we found no studies on energy management and kidney disease. And there were also a few limitations in using existing energy management programs for people with kidney disease. So first of all, there was limited evidence that energy management actually improved life participation, which again was the top priority for this population. So we would want to ensure that it does that. These interventions typically required extensive staff involvement, which may or may not be feasible in dialysis environments, which are typically sort of maxed out in terms of resources. And then the interventions themselves were really time consuming for patients and were often group based as well. So perhaps not, flexible and convenient enough for people who are on a dialysis schedule to really engage with. So I have, over the past few years, been working on developing a structured energy management program for people on dialysis called the PEP Program, or Personal Energy Planning Program. And the PEP program uses an individualized and problem-solving based approach to help people really figure out how to use energy management to achieve their life participation goals. And the program involves 3 web modules and then 4 to 6 concise one-on-one problem-solving sessions with a clinician. And really the goal is, again, to find personalized strategies to conserve energy so that the person can accomplish what is important to them. So we recently finished conducting a 1-to-1 blinded pilot randomized controlled trial of the PEP program, comparing it to an active control condition. And our primary objective was really to explore the feasibility of recruiting and retaining participants in a full-scale randomized controlled trial. But we also wanted to explore the effects of the program on life participation and fatigue. So we recruited about 20% of all English-speaking dialysis patients from 6 dialysis units in Calgary. And in total, we randomized 30 patients and retained 22 patients. So we retained just over 70% of people who agreed to participate. So first of all, with respect to the life participation goals that people set, I think this is kind of an interesting sort of side thing to look at. So we found that these really varied and they covered a lot of different areas of life. So About half were in the area of kind of self-care or household management, but many goals were related to hobbies, recreation, and leisure. And I think it's important to note because sometimes we have a tendency to focus on disability just with respect to personal care. But I think patients are kind of telling us here that life is about more than just personal care and that they do need support with some of these other areas of life as well. So some examples of the goals that people set were: I want to have enough energy to walk the dog 3 times a week. I want to have enough energy to cook dinner twice per week. I just want to be able to shower without getting so exhausted. And I want to be able to go on a ski day with my family. So we focused on these life activities that each patient considered personally important. And the preliminary evidence, again, from the pilot RCT suggested that the approach was effective at improving patients' life participation. So people who completed the PEP program went on to achieve 40% of their goals immediately after the intervention, but that increased to 65% by 3 months after the intervention. And that compared to just 20% of goals being achieved in the active control group. We also interviewed patients about their experiences with the program, and participants expressed that it had made their lives and everyday activities easier in some way. Many expressed that it gave them, new ideas and strategies. 3 participants described it as being eye-opening. Patients were positive about the goal-focused approach that we took. They liked that it was personalized. There were challenges as well. For some of the problem-solving strategies we provided were not well retained, and several participants discussed the need to be motivated to participate as being a potential limitation as well. So certainly some strengths and some areas for improvement were identified, and we're in the process of looking to address those things as we move towards doing a larger study of the program's efficacy. So that's another sort of intervention approach to keep in mind for fatigue management, is this energy management approach. So that kind of encompasses some of the ways that we can support patients with self-management of their own fatigue. So now if we move on to thinking about the healthcare team's role in fatigue management. So what can we do? So first of all, we can treat anemia. In this systematic review that looked at the impact of erythropoietin on fatigue, correcting hemoglobin levels did lead to a 35% reduction in fatigue. So addressing anemia is certainly an evidence-based strategy for reducing fatigue. Again, I think it's sort of the first kind of thing that everybody thinks of when a patient presents with fatigue, and there is a reason for that. What else can we do? We can minimize polypharmacy. We know that kidney disease patients on average take 12 different medications per day. Some of those are potentially unnecessary, and we also know that some medications like statins and benzodiazepams and other sleeping aids can actually contribute to fatigue. So I think asking the pharmacist to do a medication review and consider a deprescribing protocol to ensure that there aren't any extraneous medications, I think that can be a constructive exercise in the presence of sort of ambiguous or non-specific fatigue. We can review dialysis dosing and dialysis adequacy. Rapid fluid shifts and high ultrafiltration rates during dialysis can lengthen post-dialysis fatigue. So again, considering extended or more frequent dialysis if that is an option and if that can be worked out. We can address mood disorders like depression and anxiety. I think this is a really important one as well. So I led a scoping review that found a lot of correlational evidence linking fatigue with depression in the hemodialysis population, including in adjusted models. And although fatigue can be a sort of tricky side effect of depression to treat with antidepressant medications, it's often not as responsive to medication as some of the other symptoms of depression. I still think it's important because improvements in mood can minimize fatigue by allowing patients to engage in more activity and more exercise. So by addressing that sort of inactivity component of depression, patients can start being more active, and that's sort of a fatigue management strategy. So I think really targeting depression and anxiety is something that we can and should do. We can investigate sleep disorders as well. We know that people with chronic kidney disease are prone to a variety of sleep disorders like sleep apnea, insomnia, excessive daytime sleepiness, and restless leg syndrome and periodic limb movement disorder. So certainly assessing and measuring sleep quality and introducing an appropriate intervention whether it be a CPAP machine, medication, or introducing lifestyle changes, for example, the ones that we discussed, is something I think that we can do and should do as well. One of our roles, I think, is to educate the patient, again, about their roles in self-managing fatigue. So providing those resources, the education, the connections or referrals to enable self-management and to connect the patient with some of those self-management strategies like cognitive behavioral therapy or energy management that can be helpful. We can provide education and support to caregivers as well about kidney disease and fatigue. And they can then make the patient's social environment that much more, supportive and enabling in terms of the supports that they provide to help the patient minimize fatigue. And then finally, we can refer to others as necessary as well, involve as many people as could be helpful. So referring to occupational therapy, physical therapy, social work, psychiatry, geriatric nephrology, or the other allied health professionals you might have on your team, who can support patients in managing fatigue in sort of different ways. Again, I think there's different areas of expertise and different perspectives. And so recognizing that fatigue is so multifactorial, sort of thinking about how different members of the healthcare team might be able to help. And then finally, I just wanted to end off with thinking about how we can support caregivers in helping with fatigue management. So first of all, we can educate the caregiver about fatigue, again, so that they do know it's an issue and are receptive and supportive about it. I've had many patients who, in our energy management studies who have said, boy, I really wish that my spouse or my daughter or my caregiver could see this as well, because fatigue is kind of a sort of a silent symptom, and it can be hard, again, for patients to talk about it with their loved ones, and it's really invisible. And so, ensuring that the caregivers are educated so that they are aware and can really be supportive is important. I think we can also support caregivers in helping to communicate their thoughts, feelings, and needs as well, to really reduce misunderstandings and sort of improve communication and create sort of productive systems within the sort of family or support units, which can again reduce stress. We can educate the caregiver on how to be supportive and understanding in response to fatigue, and what the patient with kidney disease, what their needs might be, so that again everybody is on the same page and everybody is working together. We can, I think, help the patient and caregiver think through this and consider how they might be able to sort of rearrange their life roles so that everyone has a realistic and sort of doable share of responsibilities and activities. And again, involving an occupational therapist or a social worker could be helpful for this. And then I think it's important as well to remember to support and encourage family members or caregivers to engage in their own self-care and fatigue management as well. So caregivers and family are certainly at a high risk of fatigue and burnout themselves. They are also sort of dealing with those added responsibilities of kidney disease management. And that fatigue, the fatigue on the part of the family or the support systems, can also then impact the patient. So, again, using some of the patient self-care strategies we talked about, eating well, exercising, getting good sleep, finding ways to manage stress, is something that we can support caregivers with as well to sort of help manage everybody's fatigue levels. So again, just to kind of summarize, I think the take-home messages really are that, again, fatigue is very common in chronic kidney disease, and it really matters a lot to people living with chronic kidney disease. So it really is important for us to kind of actively address this and tackle this head on. The take-home message is that there are tools available that can be used to measure and monitor fatigue and chronic kidney disease. And so it's really just about thinking about the criteria of a tool that you need in your specific unit and sort of employing that tool that meets those criteria. And then the final take-home message is really, I think, that there are a variety of effective strategies that can be used to manage fatigue in kidney disease. I think oftentimes people think that fatigue is just so ambiguous and so sort of non-specific that it's really difficult to kind of figure out what to do about it. But As we've kind of gone through really briefly in the 45 minutes we've had today, there really are things that can be done and evidence-based strategies. And so I think it's really best tackled from several different perspectives and from several different healthcare team members, again, to achieve the best possible outcomes. So again, thank you so much for having me. I've really enjoyed engaging with you today, and I'd just like to thank all of the organizations and people on the screen for their support in my research and my career. And I'd be happy to take any questions now.
Thank you so much, Janine, for that. And really congratulations on this body of work. It's just so amazing to see it done in such a systematic and thoughtful way, and translatable. If anyone has questions, feel free to raise your hand and I will ask you to unmute. I think, David, you had a question?
Yes. Hi, I'm a nephrologist from Sault Ste. Marie. How are you today?
Hi, David. Nice to meet you. Thanks for being here.
Couple of questions, just to expand on a couple of points that you made. Regarding the treatment of anemia, you mentioned the erythropoietin. There are also, of course, neurological and cardiovascular effects of erythropoietin, although the evidence is kind of iffy on that. It's for some of it with stroke. Do you have any knowledge of papers looking at fatigue, particularly in dialysis? Anecdotally, I know my patients tend to feel better within a couple of weeks of EPO, even before their anemia is changed. And I have attributed that to the neurological. The second question is mentioning exercise, and it's interesting you did some studies in Calgary. Any papers on the impact of exercise during dialysis on patients' overall level of fatigue? Because I know Dr. McRae, I believe, and some others in Calgary have done work on this.
Beautiful. Okay, yeah. So to answer your first question about erythropoietin, so I'll be careful not to overstep my boundaries because I'm not actually a physician or a nephrologist. So it's not necessarily my area of expertise, but what I can sort of, I guess, reiterate or just kind of tell you is that what the literature suggests is that erythropoietin is effective for fatigue in the long term. So I don't know necessarily sort of the short-term sort of adjustments. It's interesting to hear you say about, patients can kind of take, several weeks kind of adjust, and that, potentially maybe during that period, fatigue might not improve. But again, what a systematic review has shown is that the impact on fatigue is about 35% reduction in fatigue on average, of course. So so generally speaking, erythropoietin does seem to be effective, and I guess any cons that might be there are sort of outweighed by the pros in terms of fatigue management. So in terms of exercise during dialysis, so interestingly enough, and I'm actually not familiar with the most recent sort of work that's come out in Calgary or Alberta, I think you were mentioning. So I'd actually be really interested in investigating that further. I think there are a lot of studies about exercise in general, and about exercise during dialysis. We've had a lot of interdialytic exercise sort of studies that have come out as well. It's not as common to see actually fatigue measured as one of the outcomes in these studies, which is sort of interesting in a way. I often find that there are other sort of more physiological or sort of more medical outcomes that are kind of identified as the target of intradialytic exercise, but not necessarily fatigue management. Although I wouldn't, sit here and claim that there aren't any studies, but it's not as common. And so I don't know that we have conclusive evidence on that at this point, but I would actually be really interested in kind of looking into those more recent studies from Alberta, because I think it's an important area to kind of learn more about.
Scott, question.
Great talk. Thanks, Janine.
Thank you.
Just a question about sort of how we define fatigue, and just in terms of the background. So I'd done some research many years ago, never published, but where we sort of in the exercise lab measured sort of using fatigue protocols to try to distinguish between central and peripheral fatigue. And to our surprise, when we kind of compared dialysis patients and compared to sort of sedentary controls, we seem to find that the fatigue that we measured was predominantly central. It was substantial, but really central, and not so much a peripheral problem. So I haven't kind of kept up with the literature, so I don't know if there's much in that space. But I guess my question is mostly, does the mechanism of fatigue matter, and therefore in terms of how you target it?
Yeah, that's a great question. And I think it's interesting, you know, when we sort of revisit that sort of definition of fatigue, that the fatigue is often reported to be sort of a disproportionate or even unrelated to activity or exertion, which in some ways to me sort of suggests a central component to it, that it actually doesn't matter how much physical activity is happening, people are just tired. And so I think it's certainly an important consideration. In terms of how that impacts sort of approaches to management, it's an interesting question. And I don't know that I've really considered it on a deep level before, but I think, for example, if exercise training is really a more peripheral sort of activity, but it does seem to sort of, evidence has shown so far that it is effective for fatigue management. So that suggests there is a peripheral component to it, I think, as well. But some of the other strategies that were kind of discussed, I think the mechanisms don't matter as much, particularly some of those sort of self-management strategies. So for example, cognitive behavioral therapy, energy management. Again, whether the mechanism is central or peripheral, those strategies just help to sort of make fatigue a more manageable experience for the patient, no matter what its source is. And so, yeah, those are some thoughts, but I think it's definitely a really interesting question. And I don't know that it's really been broken down very often, if at all, particularly in the kidney disease population that way. So thanks for bringing that up.
Any other questions for Janine? I had one quick question. Just wondering if you've planned a continuation arm in the PEP program. So any booster doses or any follow-up doses with respect to interventions to see if you can sustain it.
It's a great question. Sort of two goals that we would have for the full randomized controlled trial would be, first of all, to kind of look and see what the maintenance of effects are, because we didn't have a chance to look at long-term maintenance of effects. So even just looking, is there a need for a booster, I think is an important consideration. The second point is that with a program like the PEP program, part of the intervention is actually teaching self-management. So it's about teaching strategies that the patient will be able to continue to use beyond the intervention period. And so whether that sort of reduces the need for a booster, that would be kind of, I think, our goal. And with the preliminary evidence that we had from our pilot randomized controlled trial, when we looked at outcomes immediately after the intervention versus 3 months after, outcomes that actually continued to improve 3 months after, which again sort of supports sort of peripherally the hypothesis that patients are learning and practicing and using these strategies and getting better at them as they go along. But yeah, it's an interesting thing, and I think we would want to kind of look into that further for sure, and that could be some future work for us.
Thanks.
No problem.
Any last questions? All right. So thanks again, Janine, for taking the time and sharing with us, and thanks to everyone who logged on. I hope everyone has a good day, remainder of your day. Take care.
Thank you for having me. Take care.